Alright, so now we're going to pick up with the drugs for epilepsy. That's going to start on page 178. So, epilepsy is a common type of chronic seizures disorder in which the neurons in the brain become hyperexcitable and trigger electrical signals when they're not supposed to or when they're not needed. So, the unnecessary signals cause rapid and repeated refiring of the nerves in the brain, leading to the seizure. So, seizures are the body's total response to those inappropriate signals. So, if we think about what we talked about before with the neurons and the neurons firing and releasing neurotransmitters and causing electrical activity and such, we can imagine if those neurons are overfiring, which is what's causing the shaking and the jerking and the rigidness when someone's having the seizure. So when the signals reach the skeletal muscles, that's when a convulsion may occur. And the convulsion is that shaking, the stiffness, the things that happen during a seizure. So they may occur, and it could be sudden contractions of many muscles without the person's conscious control. So it means the person cannot control what's happening. The convulsion is the part of the seizure that is seen as the motor response of the brain signals. So again, this is what we can see: the shaking, the contractions of the muscles, the rigidness of the body. So other parts of the seizure activity includes changes in loss of consciousness, also a variety of sensory changing in the vision, hearing, touch, smell, and taste. So these are all, and also autonomic symptoms such as facial flushing, incontinence, nausea, and drooling. So the symptoms of the seizures vary with the area of the brain that's affected and the type of seizure that's experienced. So seizures are classified as partial or generalized, and each classification has subtypes based on the symptoms. So all of this is going to make a difference in the classification of the seizures. So let's talk about that. Okay, so box 10. So classification of major seizure types. So we have partial seizures, and partial seizures we have, I don't know why my thing is not keeping up right. Okay, so the partial seizures can be simple, complex, or partial with secondary generalization. So, sorry y'all, my computer, I don't know what's going on with it. Anyway, so the simple means that the patient is not going to lose consciousness. It's isolated or discrete movement. So it might be the twitching of one toe or a foot, might be changes in more than one of the patient's or the person's sensors. And it may be one or more autonomic symptoms such as drooling, facial flushing. And they usually last about 20 to 60 seconds. So then we have complex partial seizures, and that's where consciousness is altered or impaired, and the person does not respond to the environmental stimuli. So they may have a fixed gaze, stare, and they may be motionless. So they may perform repeated motions such as head turning from side to side, foot pedaling motion, and these usually last about 45 to 90 seconds. So a lot of times when patients have these types of seizures, a lot of times they'll report that the patient or the person a lot of times they report it from school, saying that they maybe were ignoring the instructor or the teacher, or not paying attention, or not answered when spoken to, but in reality they may be having these seizures. So then you have partial with secondary generalization. So this begins as a partial seizure with the patient retaining consciousness, and then it progresses to a loss of consciousness. So it starts out as the partial. They're still kind of aware and conscious, and then they progress to the loss of consciousness. So then we have our generalized seizures, and these are all loss of consciousness. So we have the absent or petit mal. Okay, so this is when consciousness is lost for is brief, 10 to 30 seconds, and without the posture, minimal or no change in motor activity. Then we have the tonic-clonic, or your grand mal, and this is what most of us is used to seeing, whether it's on TV or if we've known somebody in the past who has seizures. So this is often predicted by an aura or a cry. And so that aura, though, is usually so quick, and it usually happens like they have the aura. They might smell something. They may hear something. They may see a light. They may hear someone's voice. They may smell something. We had one girl who was in school before with us, and she would smell popcorn. Um, and then when she would have that smell, then she would have the seizure immediately. So the whole body, this is when the whole body convulsions. They start with the muscle rigidity, followed by powerful contractions, loss of posture. They might have urinary incontinence, confusion after muscle responses are over, usually lasts less than 90 seconds. So they have usually, once they come out of these, they have that period of the postictal period where they're kind of out of it. They're confused. They don't really know what's going on. A lot of times when they come out of it, they're so disoriented. They don't know where they are, what's going on, and they kind of want to fight because, they wake up and they have all these people over them. They have these people, they don't know what's going on. So they come out of it and they're scared. So we have atonic, which is muscle tone, loss in one or more muscle groups, and these usually last 10 to 60 seconds. We have myoclonic, which is very brief, 1 to 2 seconds, contractions of one focal or more muscle groups. It can also involve the whole body. We have status epilepticus, which is a single seizure lasting 15 to 30 continuous minutes, or a series of recurring seizures between which the patient does not regain consciousness, may be convulsive, absent, monoclonic, or general convulsion. This is very life-threatening. And as y'all get into neuro, if you haven't already, in your med-surg courses, you'll learn more about this and why it's life-threatening, because they can tend to not breathe in certain, in some of these extensive seizures. So febrile seizures, these are tonic-clonic seizures induced by temperature elevation. This usually is seen in children, and they last 15 to 30 seconds. So there's a variety of problems that can produce seizures. For example, that high temperature, like we just talked about, strokes, head trauma, brain tumors, meningitis, poisoning, especially from excess alcohol intake or drugs, may also induce seizures. Epilepsy is one cause of chronic and recurring seizures. So Although other types of epilepsy management exist, most often drug therapy is used. So anti-epileptic drugs, or AED drugs, um, or what's used to drugs that reduce or prevent seizures. So the anti-epileptic drugs are divided into traditional and newer categories. So some drug categories as AED drugs have additional uses for other problems and disorders, and we'll kind of talk about that. So traditional anti-epileptic drugs, we have the traditional ones include our phenytonin, our carbamazepine, our erythrosuximide, our phenobarbital, and our valproic acid. So although these drugs have different actions, side effects, adverse effects, and nursing interventions, a lot of the nursing implementations are the same. And many of the points to teach the patients and the family about these drugs are going to be the same. And we're going to look at box 10.6 and you'll understand why it's, even though the drugs work different, that the teaching will be very similar. So we want to make sure that we are educating not only the patient but the patient's caregiver on these high points. We also want to make sure that we're teaching on the specific drug in addition to the overall category of what they should do when they're on anti-epileptic drugs. So the older drugs have more side effects and other issues than do some of the newer drugs, but they're still used effectively today for most patients, often in a combination with the newer drugs. And so as you'll see as you go through, as you've noticed even with some of the other drugs and categories and the things that we've talked about already, is that the older drugs usually have more side effects, and the newer drugs, they work not necessarily better, but they're better because the patient does not have the side effects. And if they don't have those bad side effects, then they're more likely to continue to take their medication. So, some general nursing considerations when we have our patients on anti-epileptic drugs. And so, when we should always assess before we're giving them those drugs, we want to make sure we understand all the drugs that they're on, everything that's over the counter, anything that's herbal. And if we think about it, this is with every single drug that that our patients are on. We want to make sure that we know everything that they're on to make sure what possibility of interactions. So you always want to make sure that you're looking at the drug references for any interactions that may be there. And then as with any other medication, you always want to make sure you're getting that baseline set of vital signs, their level of consciousness, their gait. So pretty much a baseline assessment that includes vital signs. Also, you want to assess adolescents for recent changes in their height and weight. And this is because as they're growing, as they're getting taller, as they're gaining weight, things like that, they are going to need adjustments to those medications to make sure that they stay in the therapeutic ranges. Also, you want to make sure that your female patients that are in childbearing age, if they're pregnant, planning to become pregnant, or breastfeeding, because a lot of your anti-epileptic drugs are going to increase the risk for birth defects, and a lot of them enter the breast milk. And if they enter the breast milk, that means that the baby, the infant, can get those medications as the mom is feeding. Also, any patient, you want to ask them whether an aura occurs before any seizures, and then tell the patient to put on his or her call light when she feels that a seizure is about to occur. So planning, we want to make sure that we always have our patient's bed in the lower position and and raise the side rails to prevent injury. And really, y'all, with really any patient, the bed should always be in the lowest position. It always should be locked as a safety feature. Also, you want to remind them to call for help before they get out of bed, because a lot of these drugs can cause dizziness and drowsiness. You want to make sure oxygen and suction equipment is in the patient's room in case the seizure does occur. You want to make sure that it's easily accessible. You want to monitor the patient for seizure activity and be prepared to protect the patient from injury. So if the patient starts to have a seizure, we're never going to put anything in their mouth. We're not going to try to hold them down. We're not going to try to stop the seizure. What we're going to do is we're going to protect their head from injury, and then once the seizure stops, you're going to put them on their side. You also want to make sure that they understand that these drugs can cause suicidal ideations, and so you want to make sure that they understand to report that immediately to their physician if that happens. Also, that they work on the central nervous system, and they depress it to some degree. So they should not drink alcohol or take in any other CNS depressants, because that could increase those side effects. And then also letting them know that suddenly stopping their epileptic therapy can result in seizures. And then also when they're changing drugs or discontinuing drugs, they should always be tapered to reduce the risk of seizures. And when we say taper a drug, what they're doing is they're decreasing it over time, a little bit at a time, until they just completely cut out the medication. So it's a slow decrease. So that general patient and teaching points, you want to make sure that they understand the importance of following up with their physician. Also monitoring the effectiveness in the drug blood levels. So the way that we're going to determine if it's effective is, number one, are they having seizures or not? Number two, we're going to do blood levels and see if the anti-epileptic that they're on is that level within therapeutic range. And if it's not, if it's too low, then our patient's at risk for seizures. And if it's too high, if it's above that therapeutic level, then our patient is at risk of toxicity. So we want to make sure that they take the drug exactly as prescribed. Again, not to suddenly stop it. And then also for them to take missed doses as soon as possible, but not to take a double dose. So if they forgot to take their morning dose and it's 1:30 and their next dose is due at 2:30, then they're just going to take that one dose. They're not going to double dose it, and then they'll catch back up with the next dose that evening. Again, we want to make sure that they're avoiding all of those over-the-counter medications and supplements unless they have checked and verified it with their doctor. Also, again, avoiding the alcohol, alcoholic beverages, or any other drugs that can decrease the central nervous system, because severe central nervous system depression may occur. Also, for some patients, alcohol can trigger seizure activity. Also, what else when we're doing the head to toe that can trigger that seizure? Remember, anytime that you're checking Perler on your patient, you're checking their pupils for a reaction to the light, you always want to ask them if they have a history of seizures. Because if they do, you don't want to shine that bright light in their eyes, because that can trigger a seizure. You want to tell the patients and family to notify immediately if they have increasing signs of depression. Because again, those medications can cause not only depression, but for them to have suicidal ideation. So a suicidal ideation is that they're having thoughts of suicide. So they're having thoughts of killing themselves. And so we want to make sure that that is reported to the doctor immediately so they can make adjustments to the medications. All right, so we're going to come back to these drugs because as we go through the paragraphs below it, it's going to talk about the generalized information, and then you have everything in your table form here. So we have memory jiga here for our 5 traditional anti-epileptic epilepsy drugs. So we have our phenatonin. Trying to go. Okay. Oops, sorry, I lost my place. I went down too far. All right, so our phenobarbital, our valproic acid, our carbamazepine, our phenatonin, and our ethosuximide. So, our phenatonin is an anti-epileptic drug that reduces or prevents seizures by binding to sodium channels on the nerve membranes and making them less active. Okay, so highlight that. All right, and then we're talking about phenatonin. All right, so it binds to the sodium channel on the nerve membrane and makes them less active, which prevents the spread of neuron excitation. So remember, the seizures caused from the neurons firing way too much and having that excitability within that nerve ending that's shooting out all those nerve pulses. So if this binds to that and keeps that from happening, then they're going to have less seizures. So this and similar anticonvulsives are among the oldest of the drugs used in the management of epilepsy. So these can come in tablets, capsules, liquid suspensions, and solutions for injections. So the prodrug of phenatonin is phosphenatonin, which is Cerebex, which is available only IV and is used for short-term basis. So it's converted to phenatonin in the body. So phenatonin anticonvulsives are approved only for treatment of seizure disorders. So why are we saying that? The reason why we're pointing that out is because some of these other medications that we're going to talk about that are used for seizures, we do use for other off-labeled or other treatments. So what happens a lot of times with some of these drugs is that they may be giving it, maybe have been made for treatment of something else, but as they're using it, they realize that they are seeing improvement for other health problems that these patients may have. So then normally it can be used as something that's called off-label use, which means it may be an anti-seizure medication, but it may be off-used for pain, such as gabapentin or Neurontin. It is a seizure medication, but 99% of the time that I've ever seen it ordered for a patient, or any patients I've ever had that's been on it, they're actually on it for pain management. So you have to make sure that you really know why the patient is on the medication. All right, so next we have our carbamazepine. And this is our anti-epileptic drug that limits the spread of neuron excitability by altering the sodium channels of the nerve membrane. So, remember, to prevent or slowing the firing of the membrane. So remember, with the phenytonin, it binds to the sodium channel on the nerve membranes. This one, the carbamazepine, this one is actually limiting the spread of the neuron excitability by altering these channels. So this causes it to prevent or slow the firing of the neurons. So these are altering it, these are binding to it. So the structures are similar to that of our tricycline or tricyclic antidepressants. This drug is often used to control epilepsy in children. And then it's also used as a mood stabilizer. So to reduce muscle spasms. So again, this is an anti-seizure medication, but it's also used as a mood stabilizer. Okay, so let's say somebody is bipolar. Okay, when somebody's bipolar, their mood is not stabilized. They may have really big highs, they have really low lows, and so the medication helps stabilize that mood to where they're more in the middle more often than having the really high highs and the low lows. So next we have our ethosuximide, which is our anti-epileptic drugs that raises the seizure threshold by altering calcium channels on the neurons. So the number of seizures are reduced because stronger excitation is needed to stimulate them. So when we say that it rises the seizure threshold by altering the chemical channel. So what do we mean by altering or raising the seizure threshold? So what that means is that it takes more for the body to have seizures than it did before. I don't know if that's really explaining it good enough. I'm trying to think of how to put that in words, in better words, but it just means that it's going to take more for that person to have a seizure. Okay, so this drug can be help to reduce all types of seizures, but it's most effective for absent seizures. So our ethosuximide is used to reduce seizures during pregnancy because it's less likely to cause birth defects than any of the prior three that we've talked about. So next we have phenobarbital, which is a drug from the barbiturates class that raises the threshold by enhancing the action of the inhibitory neurotransmitter GABA, resulting in widespread CNS depression. So, phenobarbital. So, it's in the barbiturate class. So this is a controlled substance. Okay, so it would be needing to be signed out and have a witness for waste and things like that. So it says that it raises the seizure threshold by inhibiting the neurotransmitter GABA. All right, so since we're inhibiting GABA, which means we're blocking it, then we have widespread CNS depression. So if our central nervous system is depressed and it's not as active, then it's going to take more, means it's going to have a higher seizure threshold because it's going to take more to produce a seizure. So it's the oldest drug used to control seizures, and it does have, it's also used as a sedative agent. So phenobarbital have the longest duration of action of our traditional AEDs. It is used for all types of seizures, except for absence seizures. And it's used on a short-term basis for insomnia and anxiety. So, the drug is available in tablet form, oral solution, and solutions for injections. Also, another off-label use for this is when I worked hospice for many years, and I worked in our inpatient unit, we would give phenobarbital injections in addition to their pain medication as a adjunct to pain management. So that is another off-label use. So next, our primidone is a prodrug that is converted to phenobarbital in the body. It has the same actions, side effects, interactions, and precautions of phenobarbital. So when we say something is a prodrug, okay, what we mean by that is that the drug is taken in one way, and then it's converted in the body to another drug. Okay, so you take primidone, okay, but then once it's in the body converts it to phenobarbital. Valproic acid is another AED that raises the seizure thresholds by possibly increasing the activity of the inhibitory neurotransmitter, GABA. Not all of its actions are known, and it's often combined with divalproic sodium to increase its duration of action. So, if they take the valproic acid and they combined it with the divalproic sodium, it's going to increase the duration of action. So what that means is that it's going to enhance it. It's going to make it last longer. So that means they don't have to give them the medication as frequent. So instead of having to maybe take the drug 4 times a day, they may only have to take it twice a day. In addition to the treatment for most seizures, valproic acid is used to manage manic types of bipolar. So you want to make sure, again, like I said earlier, is if your patient is on this valproic acid, it does not necessarily mean that they have seizures. It may be that they are bipolar and that they're on it to help manage their manic episodes. So the expected side effects, the most common for phenytonin is going to be gum hyperplasia. And so what that means is that it's going to have an overgrowth of the gum. So the gums in the mouth will start to overgrow the teeth or grow up on the teeth, especially with long-term use. So other common side effects are going to be abdominal discomfort. And one good thing about phenytonin is that it does not cause drowsiness. And that's a good thing because a lot of these, especially the older anti-seizure medications, cause a lot of drowsiness. And so if you're trying to survive, and make a living, and you're trying to go to work and things like that, if you're constantly drowsy from the medication, it can interfere with your life, with living, okay? So, highlight this one. Okay, abdominal discomfort. Alright, so the most common side effects of your carbamazepine is going to be constipation, nausea and vomiting, ataxia. And so, as I mentioned earlier, ataxia is going to be related to balance in walking. So, they're going to be more unstable or unsteady on their feet. I don't know why my stuff is not highlighting and working like it normally does. It's a little frustrating because it slows everything up. Alright, so some other side effects include itching, rash, muscle weakness, and increased risk for sunburn. So if they're at an increased risk for sunburn, as a nurse, what do you want to do? You want to educate them when they go outside. If they're going to be outside, they need to use hats, or they need to use sunscreen, or wear long sleeves. They need to protect themselves from the sun. So our ethosuximide has fewer side effects than other traditional AEDs. The most common side effect of the drug is heartburn or dyspepsia, nausea and vomiting, dizziness, drowsiness, and fatigue. So, adverse effects of this drug are very rare. So, our phenobarbital and our primidone has many central nervous system side effects. So, especially the drowsiness and the ataxia. So, if we have these central nervous system side effects such as ataxia and drowsiness, as a nurse, what do we want to teach? We want to teach on safety, right? Rising slowly, not driving until they know how the medication affects them. Also, using, if needed, a cane or a walker or assistance when walking. So, additional side effects include blurred vision, dizziness, and mental status change. And these problems are most apparent when they first get on the treatment. But over time, the symptoms become less severe. So the most common side effects of valproic acid is going to be drowsiness, muscle weakness, nausea, diarrhea, and menstrual irregularities. So some additional side effects is going to be anorexia. Remember, anorexia just means loss of appetite. They'll have double vision and blurred vision. Instead of drowsiness, though, some patients who are on the valproic acid actually have insomnia. Alright, so when we talk about the adverse reactions, so phenytonin is known as a teratogen, that's not how you say it. Give me 1 second. Let me see how to pronounce this.